started. Sorry, it took me a minute. Tegrity's not working so well today, so we're going to see if it records. I don't know. It may show up, it may not, but we'll do our best. Welcome. I've missed your smiling faces. To what? So for RA and gout, I'll go through, and I think actually Dr. Schultz did a really good job of covering those topics. Like, she gave some really good information, so those are great handouts to have, very in detail, in depth. I'll go back and also post my lectures on RA and gout just to kind of tell you some of the things that I thought were important, like when I taught it. And once I have her questions, if there's anything that needs to be adjusted, don't worry. I'll take care of you. You're in the nest here, right? I'm not going to let anybody hurt you guys, so don't worry. Other things we need to talk about I can't think of. Am I missing any business, class business? All right. Well, if I've missed, there's something I'm supposed to announce or talk about that I told you guys I would announce in class and I haven't, just remind me, okay? So we're going to talk about OA today. This is probably the easiest disease state in the entire world to treat. However, like, everybody suffers from it at some point in their life, okay? So it's going to be easy cheesy. It's pretty much all OTC therapy. There are a couple of prescription therapies that are in the pipeline, and some things that we use for patients that have really severe OA that we might talk about. But in general, the name of this game is going to be being able to differentiate between a patient who's a good candidate for an NSAID versus someone who's a good candidate for Tylenol versus someone who is a good candidate for, like, a COX-2 inhibitor. Those are really our three big things we have that we'll talk about, the differences of those for patients. I want you to know risk factors for OA, things that predispose a patient to developing that disease state or suffering from osteoarthritis. Let's see. And then at the end of the day, I was just telling some students the other day, I don't know if I'm proud of myself or if I've, like, crossed over to the dark side, but I may have written the hardest question of my entire life over this lecture. So I'm going to put it out there and see how you guys do on it. If you don't perform well, we'll adjust it. But I do want to see if I can get you guys to answer it and see what happens. So we'll see. It's not that bad. I mean, come on. Not that scary, right? Okay. OA. So epidemiology stuff. I guess it's like that thing you have to cover but no one really cares about. So prevalence increases with age, right? So usually for men, it's more common in younger ages. And then once you have OA, you have it for the rest of your life. It's not like once men turn 50, they don't have OA anymore, right? But for women, it usually happens later in life, okay? So you'll see an earlier onset in men than you do women. And that's primarily because of, like, contact sports. So football, other things, silly things that young men do that cause them to have, like, trauma injuries, tearing ACLs or anything that could happen to any one of you at any time. Pretty much this is all about, like, the cartilage between your joints. Typically there's, like, this homeostasis of cartilage gets broken down and then new cartilage is made and everything's, like, all peachy keen. But in OA, what happens is it gets broken down faster than you can make it. And so then before too long, you have no cartilage and your bones are just kind of rubbing against each other, and that's when you have pain. The ends of your bones, like the ends of your femur and other bones, long bones, have, like, nociceptive receptors, what is nociception? Pain, right? So when the ends of those bones rub against each other and they don't have that cartilage cushion, it causes pain for the patient. And this is primarily the problem here, is the pain leads to that decreased range of motion. Over time, the pain and the inflammation can cause joint deformities in some of these patients. But it's usually not to the extent that we see in general with RA. Almost all RA patients at some point in their life, regardless of how well they're treated, will have some kind of joint deformity because that's just the nature of the disease. But OA patients, unless it's really severe, normally they don't have that same kind of, like, joint deformities in their fingers or their legs that you might see in an RA patient. I think that this is very similar to a graph that Dr. Schultz had in her lecture last week. Basically just showing the difference there. So you have in your normal joint, let's see if this pen works. Oh, wow. Okay. In the normal joint, you've got your synovial fluid, and where's my, oh, and our cartilage. So those are our two things that we're really working with in these disease states. In osteoarthritis, you see the cartilage gets thinned out, so it becomes very thin, and the ends of those bones kind of rub together. The synovial fluid gets really full of inflammatory cells, and it almost like it proliferates in an attempt to try to cushion the joint. So a lot of times it's like a fluid effusion that causes a lot of the pain as well. So patients may have to have a needle inserted into that joint and have fluid drawn off if it becomes pretty significant. And then in rheumatoid arthritis, that synovium, that swollen, inflamed synovial membrane can turn into that really irritating substance that can actually kind of eat away at the end of the bone, and that's why you have that joint deformity for those patients. So for OA specifically, these are some of the characteristics, changes that you might see in patients that have OA, kind of that bow-legged appearance that you might see in patients as they get OA of their knee. Knee and spine, very common places for OA to develop. We call it, does anybody know what we call another word for spinal OA? People will say I have disc disease. Yeah, they'll say I have degenerative disc disease. That's the same thing. The discs are like those cartilage that sit between the vertebrae. So you may hear a patient say that to you. It's very similar. It's just OA of the spine. Fingers, sometimes you can have OA in the joints there. Very common in people who spend a lot of time typing, like pharmacy students who take a lot of notes. So you guys maybe you can put that on workers' comp. I don't know. Risk factors for OA, obviously age. As your age increases, you are more likely to have this develop, right? Getting old sucks. Obesity. So weight is probably one of the biggest risk factors and confounding factors for people with osteoarthritis, okay? So there's one statistic that says that for every kilogram that you increase your body weight, your risk of OA increases by 10%. That's crazy, right? That's a lot. So you guys remember talking about, you may or may not remember this, but remember that force on your joints, especially your weight-bearing joints, are to the 4th power. So for every 1 pound you gain on your body, your knees experience 4 more pounds of force and pressure. It's all physics. I hated physics in college. It was awful. But at the end of the day, that's how this impacts patients. So one of the best interventions you can do for patients with OA is recommend diet and weight loss. That alone can help limit the pain these patients experience. Occupations that have lots of repetitive motions. So people who do day laborers, construction workers, they oftentimes can have some problems with OA. We talked about the sports. History of joint traumas. So patients who have, maybe dislocated a hip or another joint over time, that trauma can lead to the development of osteoarthritis in that joint specifically. Weak quad muscles. This is something that runners complain about all the time. Like, you heard of runner's knee? I had a really bad case of runner's knee last year when I was training for my marathon. And, literally there were some days I couldn't get out of bed. It hurt. Well, I could. I mean, it wasn't that bad. I got out of bed, but I didn't want to because it hurt. So, if your quads are built up nice and strong, it helps lift your kneecap off of your joint. But if your quads aren't strong, then your kneecap kind of sits back against those bones and it can rub against the bones, and that causes pain. So one of the physical therapy recommendations are often made for patients with osteoarthritis of the knee is they'll have quad training, and they'll strengthen their quad through bicycling, because biking is a really great way to strengthen your quad muscles. Are we clear on our risk factors for OA? Any questions there? Moving on. Okay, so pretty much this is what you would expect for arthritis in general. It's just like a pain in the joints, and sometimes it can be a stiffness in moving the joints. So hard time moving your knees, or even like having the ability to rotate at the waist if it's in your back. Pain usually becomes worse on exertion. So people who have OA, in contrast to people who have RA. So people who have RA wake up in the morning and they have stiffness in their joints that makes it really hard for them to get moving. Okay, so lots of RA patients may spend the first hour of the day just trying to get out of bed. And it's a really, really slow process. But once they get up and they get moving, they usually feel pretty good. Okay, their joints start to loosen up as the day goes on. It's kind of in contrast to patients that have OA. So OA patients, after periods of rest, they feel really good. But then if they try to go out and run a mile or walk a couple of miles, their knees will start to hurt, or whatever joint is affected if they do that continuous repetitive motion. Baseball players, pitchers specifically, oftentimes will get osteoarthritis in the shoulder of their pitching arm. Okay, so if they continue to pitch over and over and over, eventually at the end of the day, they're like, man, my arm really hurts, right? Crepitus. Do you guys remember Panis talking about crepitus? What is that? It's a creaking. It happens to me every time I squat. My knees, sounds awful. Makes me want to vomit. But like it's that crunching sound that happens when you like bend, you could probably hear it. I should put the microphone on it and see if I can put it out there as a learning tool. So lots of people will have that crunching in their joints because there's no cartilage there to help with that movement. So it's the bone actually crunching against the bone. So fun fact about me, when I was a little girl, I was at a birthday party for my best friend in kindergarten, and it was at the skating rink, and I fell and broke my wrist, this wrist. And then, because I was a klutzy child apparently, I also fell at my kindergarten graduation while I was still wearing my cast. I was a cow, and Old MacDonald had a farm, and I tripped on my tail, and I fell. No joke. I fell, and I landed on my cast, but my arm had not yet fully healed, so it kind of like caused my arm to be a little off-center. So when I went back, my doctor actually had to break my arm again, okay? And I remember like him walking in the room and looking at my mom and saying, this is not going to hurt a bit. And then like Bertha walked in and held me down, and he actually broke my wrist right there in the doctor's office. It was terrible. I screamed. They literally called down from like the 3rd floor of the doctor's office, and they were like, is everybody okay down there? Because it sounds like there's a lot of commotion. So I say all that to say, talking about bones grosses me out because I can remember like hearing my bones crack. And so like when I hear bones like rub against bones or talking about it, I get a little nauseous. So I'm going to try really hard not to vomit on the girls on the front row today. Which is kind of like, it's almost like some kind of like sad irony that I actually have to teach this lecture. But okay. Prognosis. So what's going to happen to these patients? Well, it depends on what joint is involved. So sometimes patients that have like OA of the back, that can be one of the most severe forms of osteoarthritis because your back is so responsible for all your movements. I mean, if you think about pretty much all the movements you do involve your back in some form or fashion. The knee, the weight-bearing joints also have lots of negative consequences for patients. And probably leads to the most severe decrease in daily activities if a weight-bearing joint is involved. Does everybody know what I mean by weight-bearing joints? Right, so your shoulder's not a weight-bearing joint. Treatment is usually just palliative, so there's nothing that we can do to reverse this. At the end of disease, oftentimes people are so severe they may do a joint replacement, like a knee replacement or a hip replacement, if there's something that can be fixed in that form. But more than that, really we just try to limit pain and decrease risk of progression. All right. Questions so far? Very good. Okay, so general approach, pretty much all the things we've talked about so far. You're going to educate your patient on ways they can reduce their risk. Physical or occupational therapy oftentimes can be useful for these patients. The problem is with insurance, typically PT or OT aren't paid for by insurance until someone's severely either have lots of pain or they can't move around or they've had surgery or something like that. And so oftentimes, most of the patients who could best benefit from PT and OT can't get it because it's too expensive to pay for out of pocket. Weight loss is probably the big one. Like I said, if you can star anything today about OA, I want you to star that weight loss is a huge intervention these patients can make. Sometimes like assistive devices like canes or other things that might help the patient move around more easily. And then medications is kind of where we come in, right? So our non-pharm treatments, we've already talked about the diet and weight loss. Some patient education things might be talking about, okay, you need to exercise, you've got to keep your range of motion up, but you need to try to avoid weight-bearing exercises. So these are those little old ladies who love aquasize, all right? They are at the pool, at the gym, every morning at 9 o'clock with their skirted bathing suit, and they are ready to get busy in the pool, okay? So these patients really benefit from non-weight-bearing exercises and movements of the joints. Biking is also a really good one. Usually running and walking, because there's so much impact there, can be harder for some patients. Heat or cold. So depending on what the patient responds to, sometimes they'll respond better to like having heat on the area, and other times they respond better to like cold packs. So oftentimes, if it's the end of a long day, let's say a patient has osteoarthritis in the knee and they went to Dollywood and they walked all over that park, and by the end of the day, they're like, my knee hurts. That patient might benefit more from like a cold pack because you want to reduce the inflammation at that point in the disease, right? What else do people say about arthritis when they say, oh, the weather's changing, old cousin Arthur's in town, right? People say that, old people, when they come into the pharmacy, or Uncle Arthur. That's usually when it gets cold, right? So people will start to experience when the weather drops, the temperature drops outside, patients will start to have their joints hurt. So in that situation, if it's like a generalized ache just because of the cold temperature, they might actually do better with the heat. So it kind of depends on when the patient's experiencing that pain. Questions? Stop me if I'm going too fast. You guys know I'm historically a fast lecturer. So I try not to be, but it just happens. You can't change who you are. Acetaminophen, #1 drug of choice, first-line drug for treating osteoarthritis. It's underlined for a reason. Okay? This is per the American College of Rheumatology. The relief with Tylenol is reported to be similar to that you get with ibuprofen or any of the other NSAIDs. But there's some, like anything else, there's some studies that say Tylenol's better. There's some studies that say NSAIDs are better. There are some that say they are no different. So you can just pick out of a hat which studies you want to look at and make your argument about anything you want to make on the topic. Let's see. Specific things that I think are really important about acetaminophen. Hopefully you guys already know some of this stuff. For OA specifically, your therapy has to be scheduled. This is not like PRN use of acetaminophen. Like these patients will take acetaminophen scheduled throughout the day all the time. That's when you get your best relief of pain. Okay? The recommendation for the dose kind of differs depending on the acetaminophen limits, right? So there's always a debate about how much Tylenol can someone have in a day and blah, blah, blah. So traditionally we've said 4 grams, right? That's like the hard limit for how much Tylenol someone can take in a day. So traditionally we've always recommended 1 gram 3 to 4 times a day as your scheduled dose, okay? But now with the new over-the-counter guidelines, and I hope this is still right. I didn't actually check this year to see if I was still correct in this or not. Sorry. But it's like 650 4 times a day is typically like the max. What is it, like 2.6 grams is the most you can recommend? Is it 3 grams over the counter? I think 3 grams, that's right. So I say that to say, if you have a patient that comes into you, and this is kind of like a CYA thing, if a patient just walks into you off the street and they say, I really think I have some, arthritis in my knee, what should I do? And you recommend acetaminophen, you probably want to stick to that 3 gram limit, okay? Because you're recommending that as over-the-counter therapy. If they, in conjunction with their physician, discuss using acetaminophen for treatment, and they ask you about a dose recommendation and the physician is okay with using acetaminophen, in that situation you can probably get away with the higher doses up to 4 grams a day, because that's kind of like a prescriptive dose. Does that make sense? So I say that to say, if you said somebody walked in off the street and just, they didn't tell you that they're a chronic alcoholic or anything like that, and they say, yeah, I want to take something for my arthritis, and you say, oh, take acetaminophen, take, 1,000 milligrams 4 times a day, and they also drink a bottle of, whiskey a day, and then 3 months from now they have liver failure and they try to sue you because you recommended more acetaminophen than they were supposed to have. So kind of keep yourself in a safe level for patients who you're just recommending it to over the counter, at least until provider status changes. And in that situation, then it might be okay to recommend more. Does that make sense? Okay. I guess really take-home messages is you always got to watch on acetaminophen. Case in point today, I was afraid to even tell you what the dose limit was because I haven't looked it up in like the past 3 months because it changes all the time. There's always some new warning about acetaminophen. That 4 grams a day is serious, okay? People have had acute hepatic failure with less than that in a day. We had a patient I got consulted on probably, I don't know, maybe 8-9 months ago at the med center. A patient with HIV that took, antiretroviral therapy at home, and he had like a head cold. And at home, he decided he would take, he was taking like Tylenol PM, okay, to help sleep. He was also taking some other product with Tylenol. And I did the math on it, and based on what he told me, he had taken like 6 grams of Tylenol a day for like the past 4 days. And he came in with acute liver failure. He recovered, he was okay, but that kind of gives you an idea of how serious this can be for patients. Make sure that you know if a patient has like cirrhosis or chronic alcohol abuse, their dose limits are actually lower, and they max out at 2 grams a day. So that's an important take-home point because, lots of people may not even consider themselves to be chronic alcohol abusers. But, technically, if you drink more than 1 drink every day, then you kind of meet the criteria. So just watch out for that. Oops, sorry. Questions about Tylenol? So, number 1 drug of choice, know how much you're supposed to give them, and remember it's scheduled for OA. Those are the big take-home points about Tylenol. Okay? NSAIDs. Okay. Usually we go to NSAIDs if Tylenol's ineffective. So, you have a nice long therapeutic trial of Tylenol, give it to them for, 6-8 weeks, something like that, and see how they do. And if they don't do well with that and they fail it, or they have suboptimal relief with Tylenol, then going to an NSAID is an appropriate option. Good next step, okay? As far as symptoms and like functional limitations, like being able to move your joints, NSAIDs and COX-2 inhibitors are actually superior to Tylenol by itself. That's one of those things where I said there are studies that prove everything. So most patients, even though I know the guidelines say that Tylenol is first line, lots of patients won't get the relief that they need with Tylenol, especially if it's more severe, and they'll need to move on to an NSAID. This slide just kind of reviews the whole NSAID pathway. So remember, arachidonic acid is kind of where things get kind of crazy. So you have some kind of tissue injury or inflammation that causes the production of arachidonic acid. And then you have your COX-1 enzyme, which is constitutional, which what does that mean? It means it's expressed all the time. A constitutional enzyme is always expressed. There's nothing that turns that on or off. It just is what it is. It's kind of like a housekeeper, okay? And then your COX-2 is inducible. So this only gets induced if you have some kind of like tissue injury or inflammation. And that makes sense because if you look at, our COX-1, typically NSAIDs and aspirin and things like that, if COX-1 is allowed to do its work and you don't inhibit it, then you end up with cytoprotective prostaglandins. So it helps protect the GI lining. It helps aid in platelet aggregation. So what are two of the big things we counsel patients on who take NSAIDs? GI bleeding, right? So they have an increased risk of GI bleeding because when you give them that NSAID, you actually block that enzyme, and then you don't get all these cytoprotective prostaglandins made, right? And the platelet aggregation is really important because that's going to make a case for why Celebrex increases your risk of cardiovascular events, okay? Because on the COX-2 side, if that's induced with different types of inflammation, one thing that gets made over here, let's see. Prostacyclin is one of the things that gets made when the COX-2 enzyme is allowed to complete its pathway. Okay, and prostacyclin actually is antithrombotic. Okay, so it actually helps prevent thrombosis. It doesn't allow platelets to aggregate. Okay, so if you block the COX-2 enzyme, okay, if you block this, but the COX-1 side of the pathway is allowed to continue, then you end up with increased platelet aggregation and increased risk for cardiovascular events. So that kind of answers the whole reason why we think that, like Vioxx, for example. Remember Vioxx that came out and then was pulled off the market because people were having increased risk of like heart attacks. That's the reason why we think that happened. This pretty much just says everything that I just told you. So remember, that COX-1, it's physiologic. It always happens. It's our housekeeper. It helps us with platelet function, kidney function, okay? That's why. So you actually can increase acute renal failure with NSAIDs, right? Did you guys talk about that in the cardiovascular module a little bit and maybe the renal module? We just forget about that time in your lives. Is that what we're trying to do? That's okay. I can understand. I'm trying to forget about that time too. COX-2, inducible, like we said. It's inhibited by glucocorticoids. So that explains why giving someone steroids decreases inflammation, because you can inhibit the production of COX-2 with steroids. Yes? And like I said, it's found in blood vessels and results in prostacyclin, which is antithrombotic. And so if you inhibit that antithrombotic effect, you kind of tip the scales on the side of, which is like thromboxane A2 is what happens on the COX-1 side. You guys remember that one? Okay. Thromboxane A2 is what causes platelet aggregation to occur on the COX-1 side of the pathway. So that's why when you block the COX-1 enzyme, then you decrease platelet aggregation. Good. Slow me down if I need to, okay? As far as like comparing NSAIDs to each other, they're all equivalent as long as you give equivalent doses, okay? So as long as you give a good solid dose of any NSAID, again, it has to be scheduled just like with Tylenol. They can't be for PRN use. You've got to schedule these for patients all the time. Then you should be able to get the same effect for those patients. There's no benefit in combining NSAIDs, but there is obviously an increase of adverse effects if you do that. This also includes like the topical NSAIDs. Okay, so if someone's taking like ibuprofen scheduled throughout the day, and then you have a prescription for Voltaren, right, or diclofenac gel, that can increase their risk of side effects because there's going to be some systemic absorption through the gel. Okay, so that's technically stacking NSAIDs on top of each other. So there's no proven efficacy between like the COX-2 inhibitor, which is what? Celebrex, right? Celecoxib, or non-selective NSAIDs. So the question is how do you decide which one you want to give them? other than the fact that NSAIDs are over the counter and they have to have a prescription for Celebrex. It really all comes down to adverse effects and what you're trying to avoid in that patient. So non-selective NSAIDs, pretty much everything we've talked about. When you look at nausea, dyspepsia, and abdominal pain, when you combine those three things, looking at side effect profiles for non-selective agents, 10 to 60% of patients will complain of one of those. I know personally, if I take like a dose of ibuprofen on an empty stomach and then I try to like lay down, oh my Lord, it's like fire in my esophagus. It burns. It's not pretty. So, imagine if you did that every day and you didn't eat with that. Ulcers and bleeding, I just put down some of the reported incidents of ulcers and bleeding associated with our non-selective agents. And then there are some factors that increase your risk of GI bleeds specifically. So these are ones that you should probably be able to pick out. Not even just for the test, but just in general. Like when you actually leave these lovely padded seats and you go out and you be a pharmacist. These are some things that you should be able to pick out in a patient that tell you maybe I shouldn't select or recommend this agent for that patient. History of GI ulcers or GI bleeds, a lot of that depends on how long ago that occurred. Okay, so if they had a GI bleed 6 months ago, then I would say ixnay on the NSAIDs, right? But if that's something that happened 25 years ago and it was kind of like an isolated event and they've been fine since, then you're probably safe to try that. But you may want to take some extra precautions in giving that patient that medication. So what might be something in addition to the NSAID that you would recommend to someone to prevent GI bleeds? Another medication maybe? PPIs? Right. So H2, PPIs, taking it with food or milk, those kinds of things. Really important. Oh, look at that. Whew. I'm so smart, I outsmart myself. There's some evidence that says naproxen is the safest NSAID, okay, as far as GI risk goes. Because NSAIDs aren't just COX-1 or COX-2. There's like a continuum, okay? And actually, I think I have that in here somewhere. We'll get to it in a minute. If not, I'll post it for you guys. But there's a continuum, like you have things that are selectively COX-1 inhibitors and some that are selectively COX-2 inhibitors, like Celebrex. But the other ones kind of sit somewhere in the middle, and they inhibit both, okay? So there's a lot of people who say that naproxen is safer because it sits closer to the COX-2 side of the pathway and not the COX-1 side of the pathway. Does that make sense? I'm then going to tell you it's kind of a moot point because now there's evidence that say that that's all BS. So I'm just telling you some of the things that you might hear because these are the arguments that you're going to get from patients or providers or other pharmacists, and I want you to be armed with information to know that they're not making stuff up, that this actually are things that have been said, okay? Let's see. That's pretty much it for that slide, I think. Yeah, GI protective medications. If you have somebody that you're worried about for GI side effects, they have a history, then you might recommend using that with like a PPI or an H2. COX-2 inhibitors, when you're talking about GI adverse effects, okay? So in looking at celecoxib specifically, there was a study called the CLASS study that showed a reduced risk of ulcers with 400 milligrams a day at 6 months. But at 1 year, there was no difference in the risk of ulcers between COX-2 inhibitor versus non-selective NSAIDs. So you can still have a GI bleed with a non-selective NSAID, or excuse me, with a COX-2 inhibitor. The SUCCESS-1 trial showed a significantly better GI profile at 12 weeks. But most of these patients are going to be taking these medications for much longer than 12 weeks. So that's not really that great of a study to say that it's so much better. And then if you use this with aspirin, which many of these patients, that's the argument oftentimes for using a COX-2 inhibitor is, well, the patient's already on aspirin, so I don't want to use ibuprofen in that patient. I want to use something that only works on the COX-2 because that's the pain one, right? There's no proven benefit there. You're still going to end up having the same risk of GI bleeds as if you use ibuprofen. So the take-home point there is there are fewer complaints from patients, but the risk is still there. So just because you give somebody a COX-2 inhibitor doesn't mean you take away the risk of them having a GI bleed. Cardiovascular adverse effects. This is another big one, so listen to me because this is huge right now. There's actually some studies going on currently about this very issue. So the approved trial, which was looking at Vioxx, that's the generic of Vioxx, led to market withdrawal because those patients who took Vioxx had twice the cardiovascular risk and events of patients who took placebo. So that was enough to say, you're out of your Vioxx, go home, okay? Celecoxib has also been shown to have increased risk, but other NSAIDs have not. Oh, sorry, wait, no, I'm on the wrong one. Yeah, doses less than 400 milligrams a day have not shown an increased risk. Sorry, read the wrong line. So typically, what are some, like, does anybody ever dispense Celebrex? What doses do you normally see? 200, right? So keeping those doses lower, technically, it's supposed to decrease your cardiovascular risk, but I would take that very lightly. The risk is still there if you're going to block the COX-2 enzyme, okay? Non-selective NSAIDs, diclofenac specifically has been proven to have an increased cardiovascular risk, but other NSAIDs historically have not been proven to have that risk. However, the Precision trial, which is supposed to be done in like September of next year, is comparing celecoxib to ibuprofen and naproxen to see if there's a difference in cardiovascular risk. Because what we now think is that NSAIDs are not good for cardiovascular patients at all. So taking an NSAID chronically, regardless of what agent you take, increases your risk of cardiovascular events. So somebody that comes to you that all these things you just learned in cardiology, heart failure, MI, arrhythmias, so on and so forth, all those things should trigger you to say this patient shouldn't take an NSAID. Okay? It happens all the time. Patients get admitted to the hospital and they'll come in for chest pain and they're on an NSAID, and we'll stop it before they leave the hospital because we're so worried about the risk. Okay? This is the chart. Does that make sense? Is that, okay, are we all good? Okay. This is the chart. I found this. I really liked it. That talks about kind of where things fall on the spectrum from COX-2 selective to non-selective and then semi-selective in the middle. So you can kind of see there's a continuum and not necessarily like one place, one or the other, where things fall. So kind of how do you decide what you're going to use? You've got to compare your risks, okay? So if they have a history of GI bleed but then no events in the prior year, then you probably want to try either a non-selective NSAID or a COX-2 inhibitor with a PPI. That's assuming that they have no cardiovascular risks, like they haven't had an MI in the past, or they don't have heart failure or any of those things. They don't have an A1C of 15, right? Because uncontrolled diabetes by itself is an independent risk factor for cardiovascular events. You guys have already learned that, hopefully. If they have a GI history and they have had an event in the prior year, then you might, in that situation, want to select the COX-2 inhibitor and definitely add the PPI, because the risk of GI events are lower with the COX-2 inhibitors, and the PPI adds a protective mechanism. If they have a cardiovascular history, you definitely want to avoid the COX-2 agents altogether, and there's even more evidence now that says we should probably avoid the non-selective NSAIDs. So that might be a patient that you would definitely try those high doses of acetaminophen and do some other non-pharmacologic therapies of those patients to avoid NSAIDs at all costs. And that might actually be somebody who's a better candidate for some of the prescription medications as opposed to just trying to use an NSAID. So if they have both, then you kind of have to decide what's my best option. So if they have both, increased cardiovascular risk and an increased GI bleeding risk, we should probably just, put them out to pasture. No, I'm kidding. Don't do that, right? There are other options. We'll talk about those kind of really quickly, kind of going through this. I've listed all the NSAID toxicities, or well, not all of them, but some of them. kind of interesting fun fact. If you have somebody that has a true sulfa allergy, like really like anaphylactic to sulfa, you might want to be careful with the COX-2 inhibitor, celecoxib, because it does have a sulfa moiety on it. So they could have a cross-reactivity there. As far as bleeding goes, remember aspirin is irreversible. So it inhibits a platelet for the life of the platelet. So once it inhibits it, platelet's done, platelet has to die, we have to make a new platelet. So platelets happen to live about 5 to 7 days, and so that's how long. If you stopped aspirin today and someone who's taking it, it would take the life of those platelets before they had platelets that were fully functional again. Okay? The others are reversible. So as the concentrations fall over time, they'll pop back off the receptors and allow the platelets to start functioning again. So you get kind of a reversal of the antiplatelet effect a little bit quicker with some of the other agents. Careful in pregnancy. There's always changing recommendations on what to do in pregnancy. In general, NSAIDs are not a good idea in pregnancy unless a patient has something like a clotting disorder, and then sometimes we'll offer them aspirin. Or something that clearly the benefit outweighs the risk. Remember that the prostaglandins that are produced through the COX-1 pathway keep the ductus arteriosus open, right? And that's the neonate or the fetus is dependent on that for circulation and oxygenation. And so if you give somebody an NSAID, theoretically you could close the ductus arteriosus and have like sudden fetal loss. Okay. Drug and food interactions. The one I really care about you guys to know on here is this aspirin one. The other ones are kind of like, whatever. I mean, they're clearly useful, but this is one I think that can really be a huge counseling point for patients. So if somebody's on aspirin for like cardioprotection and for whatever reason they're also going to take an NSAID, because of the difference in reversible versus irreversibility on the platelets, you have to be careful about when you administer those medications in relation to each other, okay? So you need to give the aspirin first, allow the aspirin to have time to work on the platelets, and then have the patient take the NSAID after that. The opposite of that is, if for whatever reason they have taken the NSAID first, like ibuprofen or whatever, they need to wait about 8 hours before they take their aspirin. I think it's easier if they do it the other way around, because trying to think, okay, when did I take my ibuprofen? Oh, it was only 6 hours ago. I need to wait 2 more hours. Seems a little complicated. So if you just counsel them, when you get up first thing in the morning, take your aspirin, and then wait until after breakfast, 30 minutes or so before you take your ibuprofen for the day. Does that make sense? Topical therapies are useful for some patients, especially if they have like one joint involved and they're not a good candidate for oral therapy. So this might be that like cardiovascular patient that we're talking about that also has a risk of GI bleeding, or somebody who just doesn't want to take medicine. You know, somebody that's like, I don't want to take a pill. I just want some like cream I can rub on it and make it feel better. Okay, so capsaicin cream. You talked about that in natural medicines or maybe OTC. So it comes from peppers, right? It actually can work really well. Things I think about capsaicin cream that are the most important to remember are about some of the adverse effects. So they have to wash their hands because they can get it in their eyes and cause burning. Another thing is like sometimes people will use that and then they'll put their socks and shoes on, like they put it on their feet, and then their feet will start to sweat, and then it really intensifies that burning. So if the area gets wet, so they need to keep that area as dry as possible while they've, it wouldn't be a good idea to put capsaicin cream on your knee and then go for a swim. That would be a poor choice for the day. You would not be winning at life on that day, that's for sure, okay?
What would happen?
Do what?
What would happen?
Oh, it would burn like crazy. I mean, it would literally feel like someone was holding a hot poker on your leg.
While you're in the pool?
What happens? Okay, so what? Do what?
You feel it while you're in the pool?
Yeah, on the wet, whatever gets wet. So what happens if you eat a hot pepper and then you drink water? It gets hotter, right? Same concept. Okay, it's the active ingredient in peppers, and so then maybe if you put milk on it, you swim in milk. I don't know, but you should not get the area wet. So they need to be counseled to keep that area dry. And then they also need to know that, again, take-home message about OA, everything has to be scheduled. Okay? You can't just PRN use this stuff. So it must be used regularly, 2 to 4 times a day. And they need to know it might take a couple of weeks before they see the full effect. So this is not something that they're going to really know, like, on day one, that it's not going to work for them. They need to give this a fair shot at working before they say no. Diclofenac gel, we kind of talked about a little bit. Good news there is it's that localized inhibition of the COX-2 enzyme specifically. You get some absorption, but not a lot. So this can minimize some of those adverse effects associated with the oral NSAIDs. So maybe, if you had a patient that only had like one knee affected by OA, and you were afraid to give them an oral NSAID for whatever reason, you might try like diclofenac gel topical instead. Glucosamine and chondroitin, does anybody recommend this, or know a pharmacist that recommends glucosamine, chondroitin, or a physician, or anybody? Yeah. Lots of people swear by it, and, they'll say it's saved their life, they feel so much better. Other people are kind of on the fence about it. The evidence doesn't really say that it's super effective, but we know that it's safe, okay? So it's not going to hurt your patients. The problem I see most often for this therapy is it can be expensive if you buy a quality product. And so if a patient's on a limited budget, it might not be the best option for them just because it's going to be an undue hardship for them to buy it. This is a really good option sometimes for elderly patients because there's such low risk in side effects. It's not going to have drug interactions with other things. However, the most recent guidelines that are posted on D2L for this lecture recommend against routine use. But still, it's a safe option. We don't know if it's an effective option. If somebody wanted to try it, I wouldn't stand in their way, is the take-home message. They do have to get to a certain dose to have any, chance at being effective. And then glucosamine sulfate is the best salt. The glucosamine HCl has not shown any activity or any effect. So the sulfate, any trials that we have that show benefit are in the glucosamine sulfate salt. Adverse effects, mainly are GI. Kind of an interesting take-home point about these, though, is you've got to be careful with allergies. Glucosamine is made from shellfish shells, and so if somebody has a shellfish allergy, then you have to be careful about what product you recommend. And if it's anaphylaxis, they might not be able to take it at all. Okay, and then chondroitin is actually made with shark cartilage. So, but it can be made from other animals too. So if somebody has a pig allergy, a pork allergy, they might not need to take a chondroitin product that's made from pigs. I don't know. Corticosteroids, I promise 2 minutes and we're done. Okay, hang in there with me, I know, but this is so titillating, we've got to talk about it. Steroids, systemic use is not recommended for the obvious reasons that steroids suck long term. Okay, they're going to make patients sick. They're going to have lots of adverse effects. If you're going to use a steroid for these patients, they prefer that you use the interarticular injections with either triamcinolone or methylprednisolone. I don't really care that you know the doses. I just put them up there just kind of for FYI. And usually these patients will get steroids about 3 to 4 times a year as needed for pain, if that's a modality they choose to help treat their symptoms. The problem with steroids injections over a long period of time is steroid also causes bone to break down. So it's like you're kind of robbing Peter to pay Paul. It helps now, but long term it may actually increase the progression of your OA. I have nothing else to say about that. Hyaluronic acid injections. This is actually made from the combs of roosters. You guys know a rooster comb? That little cartilaginous piece they have on their head. They can actually kind of mill that down and make a similar product in hyaluronic acid. It's made from other things too, but sometimes you'll hear patients say, I'm getting a rooster comb injection, and that's what they mean instead of getting hyaluronic acid injection, okay? So hyaluronic acid is in synovial fluids, and it has an anti-inflammatory effect. And so the thought is if you inject that back into the bone, you can decrease the inflammation, or not the bone, but in the joint, you can decrease the inflammation in that area, okay? They get injected once a week. Typically, they have, very low events of adverse effects, especially systemically. It's more about pain or swelling in the joint itself. But they're very expensive, and sometimes insurance doesn't cover those, and so it's harder for patients to get them. Opioids, the take-home message here is that it's better to get your joint replaced than continue an opioid long-term. Okay? They're not recommended routinely for patients who have OA. There is some evidence to say that tramadol might be useful as add-on therapy with acetaminophen or NSAIDs. So if you had that patient with like that really high GI risk and also had cardiovascular risk, you might do like acetaminophen and tramadol. That might be a useful combination for that patient. Other options that are out there, these are just some of the things that are kind of in the pipeline. Cymbalta is actually approved for OA of the spine. And so Cymbalta is my go-to drug. If I have a patient that has depression and also has like pain, Cymbalta all the way. I love it. It's great. It's wonderful. I should have bought stock in the company, but I was a student and I didn't have any money. So I'm sure you guys can totally relate. Other therapies, some things that, just kind of interesting, like doxycycline. We use that. It's also recommended. You guys remember it was a DMARD that was kind of quickly talked about with RA. There's some thought that you can also use it with OA as well. I don't really care that you know those. I just put them on there to be complete. Does anybody have any questions about OA? Pretty straightforward. Just really focus on thinking about all the things you've learned to this point. Does this patient, if I give you a patient case and a question, think about what are their risks. Okay, do they have, what's their the biggest risk for that patient? Okay, did they have a GI bleed last year but they had a heart attack? Never. Or did they have a GI bleed 20 years ago and they had a heart attack 6 months ago? What would their biggest risk be? Cardiovascular, right? So just think about those kinds of things. Think about the whole patient. Okay, if I were to give you a question like that on the exam, it's probably a good chance I will. I know the girl that wrote the question, so we talk. We know each other. She's a terrible roommate, but other things. Oh, I've got a couple